Try testing this.
I think that's
should be working, hopefully. But yeah.
Yeah, sorry guys, it's working now.
Yeah.
Okay, sorry about that. Let's just continue. Okay, sorry about that. So, all right, so we are talking about negative feedback, right? So there's actually two types of negative feedback. It's called short loop feedback and long loop feedback, all right? You guys have probably heard this before, but the main thing you need to know is that short loop feedback is just within the CNS itself, so it's only from the pituitary to the hypothalamus, whereas long loop feedback is from the periphery to any of the CNS. So it can be from the periphery to the pituitary or the pituitary to the hypothalamus. So from the periphery to the pituitary is still considered long loop feedback, even though it's only like one step, right? So just some clinical principles. So this is a page right out of a textbook. So generally speaking, in endocrine, the pathologies are very simple. It's either a hormone excess or a hormone deficiency, that's all. Okay. So you basically, as a clinician, you observe signs and symptoms and you suspect a hormone imbalance. You investigate if you're unsure where the cause is, and then you just treat. Like, yeah, the principles of endocrine is very simple. And you will find that autoimmune and cancer will make up the large proportion of the causes of endocrine pathologies. And in practice, like diabetes is about all you see. Okay, so I mentioned before that like the problems that I find with like traditional pictures of the anterior pituitary hormones. So I kind of made my own. So these are the anterior pituitary hormones, the posterior pituitary, and the hormones without pituitary or hypothalamic secretion. And the cool part about like doing my own diagram is I can just do this and show. So these are all things that you guys don't have to worry that much for this semester. And it's mainly just these 5 axes. Okay, so just a question. So I guess we'll just start from the front on the left. 10 seconds. Yeah, so the answer is E. Yeah, so again, steroid hormones are lipid soluble. Lipid soluble hormones have to be bound to transport proteins, and they will be able to diffuse through plasma membrane, and vice versa. Whereas protein-bound hormones are protected from metabolism and have a longer half-life. Okay, so I mentioned that we only need to cover 5 axes today. So I kind of lied. So first we'll talk about like the 6th one, which is like the pituitary and hypothalamus. So just very basic anatomy of the pituitary. It's known as the master endocrine gland. It's seated in the sella turcica, which is Turkish seat in Greek or Latin, I forget. And it's basically like just a little seat here, right, in the brain. And you guys will cover more about this in neuroanatomy next time. So the important thing about this is that it's located directly below the optic chiasm, so pituitary tumors can grow and compress it, and causing like visual loss, and I'll talk more about that later. So vasculature, essentially, the main arterial circulation reaches the posterior pituitary and hypothalamus easily. However, to reach the anterior pituitary, it must go through a portal circulation, and this is because of the different embryological origins of the posterior and anterior pituitary. So parts of the pituitary gland, I mean, yeah, it's not important. So anterior pituitary is derived from Rathke's pouch, which is oral ectoderm. All right. So this is important to memorize just for like buzzwords for exams. And the posterior pituitary is derived from neuroectoderm, and you can see this in the name. So the alternative name for the posterior pituitary is the neurohypophysis. So neuro, and so hypophysis means pituitary. So neurohypophysis, therefore neuroectoderm. Okay. So so basically, the hormones. So how the anterior pituitary communicates with the hypothalamus is that the hypothalamus produces certain hormones that stimulate the anterior pituitary to produce its own hormones, and these travel through the portal circulation of the anterior pituitary to reach those cells. Whereas for the posterior pituitary, it directly communicates with the hypothalamus, so there's no need for such portal circulation. So just some histology. If you stain a slide of the anterior pituitary, you basically get two types of cells. Technically chromophils and chromophores, but you just get acidophils and basophils. And the way to remember which hormones the cells produce is given by this mnemonic. Have you guys heard it before? Okay, so there's B flat and a GB. So B flat, like the musical note B flat. Okay, some of my batchmates didn't know there was a musical note. Okay, so basophils produce FLAT, so FSH, LH, ACTH, and TSH, and a GP. So acidophils produce GH and prolactin. So this is just a simple staining of the anterior pituitary. So just by this staining alone, you won't be able to tell which of these basophils produce which hormone. But if you do like additional testing, you'll be able to figure out. So basically, in the anterior pituitary, you have 6 hormones, which are produced by 5 different cells. And the overlap is between FSH and LH, produced by gonadotrophs, basically. And prolactin is the only hormone under dominant inhibitory control. What I mean by this is that, so if you cut the pituitary stalk, if you cut the connection between the hypothalamus and the anterior pituitary, prolactin is the only hormone that's going to rise in concentration because it's under dominant inhibitory control by dopamine. And it's right here. Okay, so that was the anterior pituitary. So let's just talk briefly about the posterior pituitary. You basically have 2 hormones in your posterior pituitary, oxytocin and vasopressin. And basically, the posterior pituitary doesn't actually produce its hormones in the posterior pituitary. So the hormones of the posterior pituitary are produced in the hypothalamus, which then travel down to the posterior pituitary to be secreted. Right? So the posterior pituitary doesn't produce its hormones there. Okay? So to transport the hormones from the hypothalamus to the posterior pituitary, it does so by the use of neurophysins, which are basically just carrier molecules and have no real biological purpose. So this is a summary table of oxytocin and where it comes from and also which neurophysin is associated with. So it's not that hard. So first, vasopressin or ADH is associated with neurophysin 2 because it has a double atom. All right, whereas oxytocin doesn't. And oxytocin is associated with paraventricular nucleus because like there's an O and an A here, so there's one O and A, whereas over here there's one A and O, so like vasopressin or ADH and optic, you know, sort of. Yeah. Yeah, and yeah. So vasopressin actually has 2 functions. Vasopressin has 2 functions. So it's vasoconstrictory. So vasopressin vessel constrict. So firstly, it constricts vessels, and secondly, it is the antidiuretic hormone, so it retains water. Yeah. And this is basically because it was discovered at a similar time by two different groups of people, so it has two names. Yeah. So let's talk about pituitary tumors. So, tumors can either be just compressing the area all around it, or it can secrete a specific hormone. All right. So, all tumors will compress stuff. So, the thing of interest here is the optic chiasm. So the optic chiasm is located just above the pituitary. So if you compress it, you can get visual field loss and loss of acuity, and headaches are just from compressing on other brain structures. So the classical presentation is bitemporal hemianopia. Have you guys heard that word before? Okay. So it's all in the name. So this means loss of peripheral vision. And this is what like a person might see. All right, so you can see like the medial half, but not the lateral halves of the visual fields. So bitemporal, so on both sides, temporal is like your temples, so on your lateral side, as opposed to your nasal fields, which is on your medial side. Hemi, half of visual field, and anopia means just like loss of visual, sight. Yeah. So loss of peripheral vision. And in addition, pituitary hormones can secrete specific hormones. Sorry, pituitary tumors can secrete specific hormones. So it can secrete prolactin, and prolactin is the most common type of hormone secreting tumor in the pituitary, and you will get amenorrhea in women. You can secrete growth hormone, and that will cause gigantism in children and acromegaly in adults. And this is a photo of a person with acromegaly, so it's just big everything, right? So big hands, big nose, big ears, big face. Yeah. Okay, and then you can get Cushing's disease as well. So Cushing's disease is an ACTH secreting pituitary tumor, and it's a cause of Cushing's syndrome. So there's a distinction between Cushing's disease and Cushing's syndrome, and I'll cover more about this later. So these are some other pituitary disorders, and you guys can read about it in your own time. So next question. The next person, please. Yeah, so it's B flat, and I didn't put it in order, but yeah, FSH, LH, ACTH, TSH. Okay, good job. Next person. This might be a bit tricky. Sorry? Yeah. Good job. So so the posterior pituitary and the pituitary stalk arise from neuroectoderm, and the anterior pituitary arise from oral ectoderm, and neuroendoderm doesn't exist, I think. Yeah. Okay. Let's go just the next row, I guess. Yeah, so it's D, and I included plexus here. Right, so it's worthwhile to memorize all the hormones and what level they are, but then after that, you should focus on understanding why one hormone is up and one disease or another. Okay, next person. Yeah, so it's quite an annoying question, I guess. So this is technically produced in the hypothalamus. This is an amino acid, but it's lipid soluble. and then this is just wrong. And prolactin is under dominant inhibitory regulation by dopamine. Yeah. Next question. Yes. All right. So we have a tricky question. So the answer is not binasal hemianopia, because that means the loss of your medial vision. All right. So amenorrhea is the best answer here because the most common pituitary tumor is a prolactinoma. Yeah, I think this came out for our year. I don't remember which exam. Yeah. Okay, so this is just a summary, and you guys can read it in your own time. So now so I mentioned 5 key exercises to talk about. Let's just talk about growth now. So basically growth, I'm not going to talk much about it. It's fairly straightforward and not tested much. So basically growth hormone, GHRH and somatostatin are produced by the hypothalamus to regulate growth hormone production by the pituitary. Growth hormone acts on all cells in your body as well as mainly your liver. It causes the liver to produce IGF-1, insulin-like growth factor 1, and IGF-1 is the main mediator of the effects of growth hormone and enhances all the effects of it as well. So this I think came out as a question as well. The factors that stimulate growth hormone secretion. So they aren't very intuitive, so just look through them. All right, and to figure out whether it's postprandial hypo or hyperglycemia, you just think that growth hormone increases blood glucose. All right, so it's going to be in postprandial hypoglycemia so as to increase glucose to restore it back to normal levels. So like I said earlier, whenever you're going to figure out whether a hormone is going to be up or down, just think about the effects of the hormone and just relate everything to that. It'll be helpful. So these are some buzzwords for growth disorders. It's worth looking through them, and they might come out, but I won't be going through them. Okay, so that was the first axis. That was the easy one. So the other 4 are substantial. Okay, so first let's talk about thyroid hormone, and this is the axis. And just be very aware of where you are when we're talking about endocrinology, because many of the hormones cause similar effects. So just be very clear where you are. So thyroid anatomy, yeah, you guys can read it yourself. The main surgical complication is that if you resect the thyroid, you can damage the recurrent laryngeal nerve, which is near to it, and cause hoarseness of voice. Histology, basically you have cells and you have a lumen. So the cells are follicular cells and parafollicular cells. They're called parafollicular cells because they're just in between follicular cells, just like how you have type 1 and type 2 pneumocytes, and type 2 pneumocytes are found between type 1 pneumocytes and in less abundance. So you also have a lumen, which is filled with colloid. Colloid means protein, and the main protein is going to be thyroglobulin. Okay, and yeah. So you have thyroid, you have follicular and parafollicular cells, and this is a summary table of the cells of the thyroid gland and the parathyroid gland because they can have very similar names. Okay, so follicular cells produce thyroid hormone. Parafollicular cells, and they're also called C cells, produce calcitonin, which decreases serum calcium levels. The cells of the parathyroid gland, there's chief cells, which are also known as principal cells, produce parathyroid hormone, which increase serum calcium levels. And there's also oxyphil cells, which don't do anything. So there's 2 types of cells in both the thyroid and parathyroid glands. Yeah, and the key is just not to get confused. Okay, so I'm not going through thyroid hormone synthesis, but essentially, it's going to be so this is the blood, this is the thyroid follicular cell, and this is the colloid lumen. Okay, so iodide is taken up into the follicular cell, and the follicular cell makes thyroglobulin as well. Thyroglobulin and iodide are both secreted out into the colloid-filled lumen. T3 and T4 are formed by thyroglobulin and iodide in the lumen. T3 and T4 is then taken back up into the follicular cell and then secreted into the blood. Yeah. And this is it in words. Yeah. Okay. So just a bit about the naming of the T3 and T4. It's basically by how many iodine residues they have. So T4 has 4 and T3 has 3. And this is reverse T3 if you're interested. So the transport of thyroid hormones in the body. So like I said, thyroid hormone is an amino acid, but it's lipid soluble, is an exception. So it has to be carried by transport proteins. And these are the ones I listed here. And the main one is going to be thyroxine binding globulin, which has overall a very high avidity. Yep. So peripheral actions of thyroid hormones. Basically, you have a lot more T4 than you have T3, but T3 is sort of like the active hormone and produces greater metabolic effects. So you deiodinate T4 to form T3, and T3 is the major hormone that actually like carries out thyroid hormone effects. Yeah. So the effects of thyroid hormones can basically almost all be related to metabolic rate. Okay, and we will see that later in the signs and symptoms. And it also increases glucose as well. So it does like sort of everything to increase glucose. It just breaks down everything to increase glucose, and it also breaks down bone. So overall, thyroid hormone is like a catabolic hormone. Okay, so this again is the axis of the thyroid gland, basically. So there's TRH by the hypothalamus, TSH by the pituitary, which stimulates the thyroid gland to produce T4 and T3, and T4 and T3 negatively feedback onto TSH and TRH. Okay, so all right, so when we're talking about thyroid hormone, there's only going to be two pathologies. There's only going to be hyperthyroidism or hypothyroidism. However, this just whether the hormone is hyper or hypo just refers to the free hormone. So oftentimes there may be confusion whether about the location of the problem. So primary thyroid disease is going to be pathology at the level of the thyroid gland itself, and this is consistent throughout all the endocrine systems. Primary insert organ disease equals to pathology at the level of that organ, whereas secondary disease is pathology elsewhere. So in the case of thyroid hormone, it's going to be pathology at the level of the pituitary. In terms of investigations, interestingly, they don't order both TSH and free T4 routinely. Usually in clinical practice, they just order TSH. And essentially it's because it's expensive, right? So you want to cut down laboratory testing. And also the free levels of the thyroid hormone isn't that sensitive for the disease. So in hyperthyroidism, you might get low TSH and normal T4 because of the various like compensatory mechanisms by the body. And these are some other tests that you can do. Yeah, I'm not going to go through them. All right, so you guys can just take about 30 seconds to try to fill out this table yourself, and then I'll go through it. Okay, time's up. I'm not sure if that was 30 seconds or not. Okay, so I guess I'll just show you the answers. You can decide if you were right or wrong. Okay. Okay, so how to fill out this table? essentially, you just look at the condition. So if it's hyper or hypo, you start off by filling up the free hormone column. So in primary and secondary hyperthyroidism, you're going to get high T3 and T4. All right. And then after that, you try to sort of work out what the levels of the other hormone is. So in primary hyperthyroidism, you're going to have negative feedback by the pituitary, so TSH will be low, whereas in secondary hyperthyroidism, it's going to be high, and vice versa. And so you might find it helpful to think about, so generally speaking, if it's a primary problem, you're going to have, the hormones are going to be in opposite directions because there's active negative feedback. Whereas in secondary hyperthyroidism, like something else is causing the T3 and T4 to be up. So like negative feedback doesn't exist. So the hormones are going to be in the same direction. Yeah. Okay. So these are the signs and symptoms of hyper and hypothyroidism. And all of them can basically be related to metabolic rate. So just think about it in terms of metabolic rate and try to work out whether something is hyper or hypo. Yeah, it's fairly intuitive, I guess. So in hyper, you get sweating, weight loss, heat intolerance because you're sweating, and you can get diarrhea as well. Whereas in hypo, you get the opposite. So probably the only one difficult to understand is amenorrhea in hyperthyroidism and menorrhagia in hypo. So either can cause like either, but amenorrhea tends to be more in hyper and menorrhagia tends to be more in hypo. And like the easiest way to think about this, to remember this, is just to imagine like an extreme athlete, right? So extreme athletes don't have periods, right? Yeah, so extreme athletes hyper, and then yeah. As to like why, it's really like complex physiology involved. So this is one that I recommend you don't bother trying to understand. Okay, so in terms of thyroid disorders, it's going to be hypo or hypo, and I just listed the causes of each. Basically, Graves is the most common cause of hyperthyroidism, and Hashimoto's is not the most common cause of hypo, and it's actually iodine deficiency. So I'm just only going to talk about these two today. So, Graves' disease. So in both Graves and Hashimoto's, these are both autoimmune thyroid disorders, all right? And there's actually the same autoantibody stimulating the TSH receptors of the thyroid follicular cells. So your thyroid follicular cell has like receptors for TSH to bind to affect its function. And in both Graves and Hashimoto's, there are these TSH receptor autoantibodies. However, they have different effects on the thyroid gland itself. In Graves, they stimulate the follicular cell to produce more thyroid hormone, whereas in Hashimoto's, they inhibit it, right? And so this is because these TSH receptor autoantibodies are actually split into two types. So there's like thyroid stimulating immunoglobulins, which is found in Graves, and there's thyroid binding inhibitory immunoglobulins, which are found in Hashimoto's. Yeah. Okay. So, so for signs and symptoms of Graves, you guys have probably all covered it in like OSCE and stuff. But exophthalmos, peripheral myxedema, and thyroid acropathy are all specific signs of Graves and are not found in other causes of hyperthyroidism. Okay, so these are important symptoms to know. Thyroid acropathy is basically clubbing found in thyroid disease. Actually, you also get non-pitting edema in Hashimoto's, right? But for the sake, and you get it around the shins as well, and they both look like this. But for the sake of Monash exams, if you see the word pre-tibial myxedema, it's only Graves. It's not Hashimoto's. Okay. Yeah. Okay. Next person. Yep. So TSH is the first line test to perform for any thyroid disorder. But like often they just do T4 anyway. Okay. Next question. Sorry? Okay, so it's actually this. Okay, it's not that intuitive, okay? Okay, so the thought process is, so you see low T4, so hypothyroidism, and low TSH, so it's secondary hypothyroidism, okay? So the problem is not at the thyroid gland itself. This test doesn't tell you anything. This test, and this test all are related to the thyroid gland, right? And this is the only test that investigates a secondary cause of hypothyroidism. Yeah, it's not an easy question. Okay, so talking about goiters. Goiters are found in both hyper and hypothyroidism, and yeah, actually I'm not going to talk about it. So these are all the buzzwords for it. Yeah. So yeah, okay. Let's move on. Next person. Sorry? Yeah. So it's this. Yeah. All the rest are found in thyroid. All the rest are found in Graves. And these three signs are specific to Graves. Yeah, so thyroid acropathy is just clubbing found in thyroid disease. It has a different name, okay. Yeah. Okay, next person. Yeah, it's A. Okay. So this is a buzzword for Hashimoto's. You guys learned in your thyroid presumably, that if a mass rises during swallowing, it's either a goiter or a thyroglossal cyst. So thyroglossal connects the thyroid and the tongue. Glossal means tongue. Okay. So if it's connected, so a thyroglossal cyst is basically like an embryological remnant of like the tongue development and stuff, and it's basically connected to the tongue. So if you stick your tongue out, it's going to rise because they're connected. Right? So if it remains fixed, it's not a thyroglossal cyst, so it's a goiter. And a goiter is found in both hyper and hypothyroidism. Okay, next person. Okay, it's actually D. Okay, so so sorry, for the purposes of Monash, pre-tibial myxedema only refers to Graves. Okay, so and these are all only found in Graves. These are all only found in hyperthyroidism as well. Dullness on percussion over the manubrial sternum is just referring to a goiter, and a goiter can be found in either hyper or hypothyroidism. Yeah. Any questions? Okay, so I'll cover the treatment of hyperthyroidism. So generally speaking, it's just carbimazole first line, and Propatal Uracil is second line if carbimazole is like contraindicated. And it's specifically indicated for maintenance therapy in the first trimester of pregnancy as well. So, and this is because carbimazole is like teratogenic in the first trimester. So like the timeline would be that the patient will be on carbimazole, then gets pregnant. In the first trimester, you switch them over to Propatal Uracil, and after the first trimester, you just switch them back to carbimazole. That's all. And beta blockers can be used for symptomatic relief, right? Because it can stop the tremors and stuff. And so this is first line treatment. If this fails, you can proceed on to radioactive iodine or thyroid surgery. Yeah, and these are the details. I will not cover them. Okay, so yeah, so importantly for thyroid surgery, if you're removing the thyroid in hyperthyroidism, you can basically cause hypothyroidism, right? So the patient will probably need treatment with thyroxine, which is T4 lifelong. Okay. Okay, so treatment of hypothyroidism. In general, in endocrine, it's easier to treat hormone deficiency than hormone excess because you can just give the hormone, right? So this applies to anything. If a patient is low in potassium, you just give potassium, etc. So treatment of hypothyroidism is very straightforward. You just give T4. In the event of a mixed edema coma, which is if a patient suddenly has an extremely low T3 or T4 hormone and goes into like basically a coma, you can give T3 because it acts faster, basically, or you can give T4. That's it. Okay, next person. Yep. So it's A. Yeah. So carbamazole first line. Yeah, pretty much. That's it for hyperthyroid already. Next person. Okay, so B is a good answer, but the answer is actually C in this case, for I guess 2 reasons. Firstly, patient is in a coma, so you can't take any oral meds, so you have to give him IV. And secondly, this is T3 and it works like better acutely. But for long-term treatment, it will be T4. Okay. So this is another summary. Okay, so now so we just talked about thyroid, so now let's talk about parathyroid. So we are here now, and importantly, the parathyroid glands do not have a pituitary or hypothalamic regulator. Okay, so it differs from the thyroid gland in this regard. Okay, so just anatomy of the thyroid gland. Normally, you have 4, 2 on each side, and they produce parathyroid hormone. And you have 2 arteries, 3 veins, like the thyroid. So the 2 cells in the parathyroid gland. Chief cells, which are also known as principal cells. So there's principal cells in the kidney as well, but they are spelled PLE, all right? And there are chief cells in the gut as well, okay? So don't get confused. Yeah. So chief cells produce parathyroid hormone, and there's oxophyll cells which do nothing. And this again is the comparison table, so don't get confused between the cells. So the parathyroid gland regulates calcium levels. Okay, so speaking about calcium, basically there's 3 areas that are involved in calcium regulation. Calcium is absorbed in the intestines, it is excreted by the kidneys, and is largely stored in bone. Okay. So there's 3 main hormones affecting calcium homeostasis. There's parathyroid hormone, which increases calcium levels. There's vitamin D, which increases calcium levels as well. And there's calcitonin, which is supposed to decrease calcium levels, but in the normal human, it has like no effect. But you can give calcitonin like as a treatment, and that like if you give it in high amounts, it can lower calcium concentration. So this is a summary table. Don't be bothered by it. The only things I need you to know are this column, okay, and yeah, this column. Oh, you can't see. Okay, the 4th column, the plasma column, right? So the effects of the calcium and phosphates. Yeah. Apart from this column, apart from that 4th column, all you need to know is that the main effects of parathyroid hormone are the kidneys. The main effects of vitamin D is at the gut, and calcitonin does nothing. That's all you need to know. Okay. So apart from these 3 hormones, there are also some other hormones in your body that regulate calcium levels. First is parathyroid hormone-related protein, PTHrP. Only thing you need to know about this is that it's associated with hypercalcemia of malignancy. At this point, that's all you need to know. But to go into just a little more depth, so if you have like cancer in your body, the cancer first has effects on like the surrounding areas and stuff. It can also cause paraneoplastic syndromes. Paraneoplastic, so para means on the side of, and neoplastic just means cancer. So the word means just a side effect of the cancer. Okay, So it can cause paraneoplastic syndrome and secrete this specific hormone called PTHRP, and that can increase calcium levels. Yeah, for the purposes of exams, just memorize this phrase and this protein name. Yeah. Apart from this, there's also estrogen, cortisol, and thyroid hormones that can affect calcium levels. So estrogen, sorry, not really calcium levels, but bone. So estrogen is protective of bone and will lead to deposition of more calcium in bone. Cortisol and thyroid hormone are catabolic and break down bone. Okay, so calcium in the body, interestingly, it's mainly carried in the free ionized form. So 50% of it is in free ionized form, and this is in comparison to other things that you guys are learning like T3, T4, and steroids, which are mainly going to be bound to proteins. Yeah. Okay. So a topic about hyperparathyroidism. So again, your secretion of parathyroid hormone by the parathyroid gland is going to increase calcium levels. Okay. So you have primary, secondary, and tertiary hyperparathyroidism. Again, any primary endocrine disease is a problem at the level of the gland itself. So this is a problem with the parathyroid working too much. So this causes increased calcium levels. There's secondary hyperparathyroidism. So this is the parathyroid glands over secreting hormone due to hypocalcemia, so as to bring calcium levels back to normal. So you can see here, because the parathyroid glands don't have a pituitary regulator, the definition of the secondary disease is going to be different from the thyroid gland compared to the parathyroid gland. Right? And there's also tertiary hyperparathyroidism, but you guys don't need to know about it. Yeah, so importantly, calcium levels are up in primary hyperparathyroidism and they are low in secondary. And you guys can just work it out in your heads. Why? Okay. So signs and symptoms of calcium disorders. So there's hypercalcemia or hypocalcemia. Hypercalcemia is going to be stones, bones, moles, groans. Have you guys heard of that? Yeah, okay. So it's very easy to remember. And hypocalcemia basically cause tetany, which is like increased spontaneous depolarization by other cells, which causes like involuntary muscle movements. And this is because calcium is an inhibitory ion of the sodium voltage gated channel. Okay. So if you have low calcium, you have less inhibition of the sodium voltage gated channel, which increases the risk of spontaneous depolarizations. So there's two signs for hypocalcemia that you test for in your OSCE. So the Shostak sign and Trousseau sign. Shostak, so the way to remember this is that Shostak ends with like tech, and tech sounds like tap. So you're like tapping your cheek. Or the other way is it starts with CH, and cheek starts with CH, and Trousseau sign is just the other one. And so you perform Shostak sign in the OSCE itself, and you say that you would ideally perform Trousseau sign because you don't have the time for it. Okay, next person. Yeah, okay, so it's B because of the paresthesia and there's a clear description of Shostak sign here. All right, next person. 5 seconds. Just make a guess. Okay, so it's A, right? So it's a bit complicated, but the thought process is that you are vitamin D deficient, so you're going to have reduced ability to absorb calcium from your gut. That lowers your calcium levels, and so PTH increases in response to the low calcium levels. Yeah, it's a bit of a long chain of events, I guess. So this would be secondary hyperparathyroidism. Okay, next person. Yeah, so it's D. So this question is basically grilling you on the different cells and where they are produced. So PTH is produced by the parathyroid gland and specifically the chief cells of the parathyroid gland. Calcitonin is produced by parafollicular cells, and they're also called C cells because they produce calcitonin. PTH release there's no pituitary involvement in this, so it's just directly controlled by serum calcium levels. This is true, and this is not true. Yeah. Okay, next person. Sorry?
Why is E wrong?
Why is E wrong? It's basically negative feedback that is the critical rule. Yeah. Okay, next person. So the answer is B. Yeah, causing hypercalcemia, causing stones, bones, groans, bones. Okay, so the main condition to talk about in relation to calcium and parathyroid glands is osteoporosis. Given by the name, osteoporosis, porous bone. So this is a condition where you have like insufficient bone deposition in your bones. Okay, and this increases the risk of minimal trauma fractures. So a minimal trauma fracture is basically a fracture that you sustain if you just fall from standing height, right? So if I were to just fall down from here, that would be a minimal trauma fracture, as opposed to like if I was running and then I fell, that would be not a minimal trauma fracture. Okay. So osteoporosis is basically caused by an imbalance between bone resorption and bone deposition. So you have greater bone resorption than bone deposition. And it occurs most in the joints with highest content of trabecular bone. And these bones are the hip, the wrists, and the lower vertebrae. So the hip, the wrists, and the lower vertebrae, these have like the highest proportion of trabecular bone. So osteoporosis commonly affects these areas. Okay, so clinically, you measure. So to diagnose osteoporosis, you measure the bone mineral density of a patient. So you measure this by a DEXA scan. And the diagnosis is by like a T-score of negative less than 2.5 or lower, right? Whereas osteopenia, which is the condition where you have reduced bone mass but doesn't quite fit the definition of osteoporosis, is negative 1 to negative 2.5. And this is what an example result might look like. So in the regions L1 and neck of femur, it shows your bone mineral densities. Different areas have different bone mineral densities, so you can't just use one area. And it shows the T-score. So the T-score actually compares your bone mineral density to that of a healthy person, basically, which is not that intuitive, I guess. That it compares that way. Like you would expect it to be compared to like people of your same age and gender, but that's actually the Z score. And the reason why you use the T score to diagnose osteoporosis is that you're not really looking to compare between like, your age group. You just want to ascertain whether the patient is going to be at risk of fractures, and if the patient is, then you want to treat the patient. So you're not looking to compare. Yeah. So a bit about bone homeostasis. So I'm not going to go through this. Essentially, rank is found on osteoclasts, and rank L, rank ligand, is found on osteoblasts. And the easy way to remember this is that osteoclasts eat things up, so the word is shorter, so just rank. Yeah, and estrogen is protective of bone by like these complex mechanisms. So osteoporosis prevention, physical activity helps a lot. Exercise helps a lot, but the key is to not do weight-bearing exercise because that might actually give you a fracture. So don't do weight-bearing exercise in osteoporosis. And you can give calcium and vitamin D as well. And you can also give hormone replacement therapy, and you guys can look through this if you want, but it's not very important. So the pharmacological treatment of osteoporosis can be broken down into anti-resorptive or anabolic agents. So drugs that either reduce the breaking down of bone or increase the deposition of bone. So for the drugs that reduce the breakdown of bone, biphosphonates are going to be your first line specifically for postmenopausal women, right? And this is a drug that's really very commonly used. It has quite annoying side effects. So the ones that you need to know for Monash are osteonecrosis of the jaw and atypical fractures, right? And this is really important as well, corrosive esophagitis, because it's really irritating to your throat. And the way to prevent this is to take it with water and remain upright for 30 minutes. For those of you who are curious, this is biphosphonates are not administered every day, so patients don't have to endure this every day, but it's once a week. Yeah. So I'm not going to talk about all these other drugs. So this is the main one, alendronate, and all the other drugs are good to know. And you should memorize the things in bold or red. That's all good. Yeah, this is red, so memorize it. Yeah. So, yeah. Okay. I'll just skip this question actually, because no, it's not. You guys, I didn't cover it. Okay. Okay. Next person. Yep. So it's B. It's a bit annoying, a bit of an annoying question, I guess. It tests like your understanding of the class of biphosphonates with like pyrophosphate and a lot of stuff. But otherwise, it's okay, I guess. So this is a summary. Yeah. Okay. So now let's move on to adrenals. So again, this is where we are. Keep in mind the big picture whenever you study endocrine. And so the adrenal glands are another endocrine system that do have a pituitary and hypothalamic regulator, and this is very important, as you will see later. Okay, in terms of anatomy of the adrenals, I'm not going to cover them. They're basically a retroperitoneal organ, and they comprise an outer cortex and inner medulla. The outer cortex produces steroid hormones, and the inner medulla produces catecholamines, so like adrenaline and noradrenaline. Yeah. Okay. So there's three components to the adrenal cortex. So the zona glomerulosa, zona fasciculata, and zona reticularis. From a histology point of view, the only thing important is that zona fasciculata is the thickest part of the cortex. So you guys can't see my mouse, but if you look at the diagram, you can see that zona fasciculata is like the thickest layer, right? And it contains spongiocytes. Yeah, that's about all you need to know from a histology point of view. Okay. Okay, so this is a good table. It's a good flowchart on the types of hormones produced by the adrenal glands. So in the cortex, there's the zona glomerula cell produces mineralocorticoids, which aldosterone is an example. Zona fasciculata produces glucocorticoids, an example is cortisol. Zona rectificaris produces androgens, and the adrenal medulla produces catecholamines, which are adrenaline and noradrenaline. So a bit about the structure of steroids. So basically, there are different types of steroids, but all the hormones produced by the adrenal cortex are all steroids. All right. So glucocorticoids and mineralocorticoids like aldosterone are all considered steroids. Androgens are also steroids, right? And apparently there are 3 types of sex hormones, and androgens is only one of them. But yeah. Okay. Production of steroids. Basically, steroids are produced from cholesterol, and this process is dependent on the star protein. And for the synthesis of cholesterol itself in the body, the rate limiting step is HMG-CoA reductase. That's all you need to know for this slide. Okay. Again, steroids are lipid-soluble hormone, so they need carrier proteins in the plasma. So they have carrier proteins in the plasma. So and the receptors are going to be intracellular because they can diffuse through the plasma membrane. So I'll talk about mineralocorticoids, glucocorticoids, and androgens one by one. So in the top left corner of the slide, there's a picture of where we are. So right now we're on the first line of it. So mineralocorticoids is going to be, an example is going to be aldosterone, produced by the zona glomerula cell. And it's part of the renal-angiotensin-aldosterone system. So it's going to increase sodium and water reabsorption and excrete potassium. So in excess, it can cause hypokalemia and hypertension from the sodium and water reabsorption. So, okay, this is important. So the release of all these steroids, cortisol, aldosterone, androgens, are all greatest in the early hours of the morning. Yep, and I'll cover this later as well. So some problems that can go wrong with mineralocorticoids. Conn syndrome is an aldosterone-producing adrenal adenoma, which causes an increase in sodium reabsorption and sodium reabsorption and potassium excretion. And so it causes hyponatremia and hypokalemia, and causes hypertension as well. So the differential diagnosis for Conn syndrome is going to be renal artery stenosis. Exactly the same thing. The only thing different is that you have high renin in renal artery stenosis. And you can work this out later after this lecture why. Okay. And then Addison syndrome, I'll cover it later. And just for like a recap, spironolactone is an aldosterone antagonist and causes hyperkalemia. Okay, so now we're on the second line of the top left diagram. So we're talking about glucocorticoids. So there are 3 functions: metabolic, anti-inflammatory, and immunosuppressive. And the main one that's relevant in endocrine is going to be metabolic, but it also has other uses. So it's a dipeptogenic hormone because it increases blood glucose. Yep. And it's a catabolic hormone as well, and breaks down everything. So it breaks down bone, muscle, whatever, really. So pathologies that are related to glucocorticoids. Main one is going to be Cushing syndrome. So Cushing syndrome is any state of chronic glucocorticoid excess. So there's various causes, most commonly caused by drugs, all right? So penicillin or hydrocortisone, or cancers. So Cushing's disease specifically refers to an ACTH secreting tumor in the pituitary, and is a cause of Cushing syndrome. All right, so there are other causes of Cushing syndrome as well. And Addison disease is relevant here as well, and I'll cover it later. Okay, so signs and symptoms of Cushing syndrome. So there's this acronym, but So the major ones are going to be in the acute phase. In the acutely, you can get hyperglycemia. So I'm referring to like if you're administering prednisolone to a patient. So the side effects are going to be acutely, you can get hyperglycemia, you can get fluid retention causing weight gain, and you can get psychiatric effects as well. Okay. In the long run, you can get central obesity, you can get like thinning of skin and easy bruising, osteoporosis, and immunosuppression. Yeah. Okay, so this is important. So the investigations for excess cortisol. So any excess cortisol chronically is going to be Cushing syndrome, but you sort of need to determine why. Of this page that I also put in earlier, because it shows you like the principle behind it. So if you're suspecting hormone excess, you test for the cause by inhibiting the gland that produces it. So if there's a hormone secreting tumor, then this will fail to suppress by normal feedback mechanisms through the pituitary, because the tumor is not at the pituitary, right? So some key principles for the dexamethasone suppression test. So it's used to diagnose Cushing syndrome of any cause, and in particular, it separates Cushing's disease from other causes of Cushing syndrome, and I'll go into more about that later. So dexamethasone is an exogenous steroid. Okay, so it's an exogenous steroid, and it functions and is structurally similar to cortisol, right? So it's going to inhibit pituitary ACTH production by negative feedback. Second principle is that the dexamethasone suppression test measures cortisol levels, not ACTH levels. All right, and thirdly, cortisol is lowest at night and highest in the morning. All right, so the test is basically you administer dexamethasone to the patient the night before, and then you measure his cortisol levels in the morning to see whether, so cortisol levels are normally high in the morning, and you see whether the cortisol levels are suppressed. All right, so take about 30 seconds to do this yourself, and I'll go through it. Okay, let's go. Okay, so for the first column, for the first row, if you are normal, all right, you're going to have high cortisol in the morning. Oops. All right, okay, let's just keep it as normal. So you're going to have normal cortisol and ACTH in the morning. And if you administer just a little bit of dexamethasone, it's enough to suppress the pituitary production of ACTH, and that will cause a low cortisol in the morning. So it'll be suppressed in the morning with either low dose or high dose of dexamethasone. However, if you have an ACTH secreting pituitary tumor, like in Cushing's disease, so you're going to have normally high cortisol and high ACTH in the morning. And if you just give a low dose of dexamethasone, it is insufficient to suppress the hormone production of the pituitary tumor. However, in high dose, it is sufficient. This is the results. And this is basically because the dexamethasone test specifically, like why you even have a low dose and high dose test in the first place, is specifically tests for Cushing's disease. Yeah, so if you get these test results, it is Cushing's disease. So third case is Cushing syndrome caused by an adrenal tumor. So an adrenal tumor isn't at the pituitary, it's at the adrenals. So you get high cortisol, but there's still active negative feedback. So you get low ACTH. It is the dexamethasone suppression test doesn't suppress it at all because the hormone production isn't at the pituitary. So by definition, like ACTH can be suppressed. Okay. And lastly, Cushing's syndrome by an ectopic ACTH tumor. So similarly to adrenal tumor, it's not going to be suppressed at all by dexamethasone. However, since it's an ACTH secreting tumor, ACTH levels and cortisol levels are going to be high in the morning. So it's like this. Any questions? Okay, it's a lot to take in, so just try to go through it yourself later on and just go through it slowly. And I'll upload like the full slides with, so you can remove like the boxes and stuff.
Sorry, what does dexamethasone measure?
So the dexamethasone test measures cortisol levels in the morning. Sorry, who asked that question? I don't, oh, sorry. Yeah, does that answer your question? Okay, so that was cortisol. Okay, so now let's move on to the third part of the adrenal cortex, which is androgens, right, produced by the zona reticularis. So honestly, the only thing you need to know about this is this. Okay, so you just need to know this one condition for this part of the adrenal cortex. So congenital adrenal hyperplasia is basically, given by the name, increase in cell number of the adrenal glands, and it's from birth. So it can be due to various enzyme defects, but the most common one is 21-hydroxylase. 21-hydroxylase is involved in the synthesis of both mineralocorticoids and cortisol. So you guys can't see my mouse, but it's at the middle of the slide, that enzyme. And can you guys see it? Okay, so yeah, just look at your own PowerPoints, guys. So it's so the 21-hydroxylase enzyme is around the middle of the slide on the left, and there's a line stretching out from it that only involves the production of mineralocorticoids and glucocorticoids. So it doesn't involve androgens. So in this disease, you basically get cortisol and aldosterone deficiency, but not androgen deficiency. In fact, because of your aldosterone and cortisol deficiency, you get an increase in ACTH production by the pituitary, and that causes increased androgens. All right, so you get cortisol and aldosterone deficiency, but you get increased ACTH and androgens. Very common question. Okay, so we just covered all the three parts of the adrenal cortex. So this is an inhibitory condition. Addison's disease. So it's a state where you get inadequate cortisol and occasionally aldosterone production by the adrenal glands. And main cause is autoimmune. Right? And so it's associated with other autoimmune conditions because autoimmune conditions tend to run together. So it's associated with all these other things. And it's also more common in women because women are at higher risk of autoimmune conditions for some reason. Right? So the signs and symptoms are pretty easy to memorize. So it's just that everything is down and dark, all right? So BP is down, appetite is down, weight is down, mood is down as well, and increased pigmentation, like so it's dark skin. And the reason for this is you have so your adrenals aren't working properly, so there's increased ACTH produced by the pituitary. Right? So the excess ACTH actually acts on melanocytes, and that causes the production of melanin. Yeah. Okay. So now talking about the adrenal medulla. So at the fourth row of the top left diagram. So the only thing we need to know is a pheochromocytoma, which is an extremely rare tumor of the adrenal medulla, and you get episodes of like very heightened SNS activity basically. So you get episodes of sweating, palpitations, hypertension. Yeah, that's basically it for adrenals. So next person. Yeah. Wait, sorry, who is it? Sorry, who is it? Yeah, okay, sure. Yeah, say, all right. So this is congenital adrenal hyperplasia. Sorry again. So the question was, is that a type of hypoadrenalism? I guess so, but I guess, but it only affects cortisol and occasionally aldosterone, and it doesn't affect androgen, so I'm not sure whether you can call it that. So yeah, I'm not sure. Okay, next question. Okay, so the answer is B. Okay, so the keywords are hypernatremia and hypokalemia. So in hypernatremia and hypokalemia, there's going to be the cause of that is going to be an increase in aldosterone, right? And of the options listed here, Conn syndrome is the only one associated with increase in aldosterone, right? Okay, this is a difficult question. Okay, it's okay, it's okay. All right, so the answer is this. Okay, so this question said that there's increase in aldosterone. However, I mentioned earlier that like a differential diagnosis for Conn syndrome is renal artery stenosis because they both cause increased aldosterone. So the most appropriate investigation to perform is going to distinguish between these two causes. So the aldosterone renin ratio distinguishes between Conn syndrome and renal artery stenosis. Yeah. All right, next question. Sorry? Okay, so it's actually C. Okay. Okay, so hyponatremia and hyperkalemia run together, right? Because an increase in aldosterone causes both hyponatremia and hyperkalemia, right? And the high plasma ACTH, option E, causes hyperpigmentation, which is because of its effects on melanocytes. So the only option left is hypertension, and hypertension isn't found in existence disease because it's going to be down, and it's due to low aldosterone, causing low sodium and water retention. So take 30 seconds to attempt this table. Okay, let's go. My laptop is running out of battery, so I need to go. All right. Okay, so in Cushing's disease, so the keyword is disease here. I'm referring to specifically the ACTH specific, ACTH producing pituitary tumor. So both are up. All right. In Addison's disease, it's primary hypoadrenalism. So cortisol is down and ACTH is up by negative feedback. Okay. In congenital adrenal hyperplasia, it's similar. So cortisol is down and ACTH is up. Right? And in a patient taking exogenous steroids, that inhibits the pituitary production of ACTH, which causes low cortisol as well. And so the fourth scenario is essentially like the dexamethasone test. That might be a way to understand it. Okay. Next person. Yep, so it's D. Yeah, it is D. Okay. I'll just speed up, guys. So can the next person just give all the yeah. Okay. So A is the capsule of the adrenal gland, right? So the adrenal cortex starts from B. Yeah. Okay, so the answer is BCCE. Okay, BCCE. And I'll leave you guys to work out why. Okay, because my laptop is dying. Okay, so lastly, I'll talk about the endocrine pancreas, all right? And the hormone, the main hormone involved is insulin, and so importantly, the endocrine pancreas doesn't have pituitary or hypothalamic regulation again, like the parathyroids. Obligatory joke. Okay, so in the pancreas, there's exocrine and endocrine components. The exocrine components, you guys covered it in GI, so it secretes pancreatic enzymes and fluid and bicarbonate. So in the endocrine pancreas, so the main cells involved are the isolates of Langerhans. So it's important not to confuse these cells with Langerhans cells found in your skin, which are dendritic cells involved in immune stuff. Okay, so the faculty favorite question. Yeah, basically this guy called Langerhans invented a lot of things. Found a lot of things. Okay, so in the endocrine pancreas, you have beta cells and alpha cells. Beta cells and alpha cells. So your beta cells produce insulin, your alpha cells produce glucagon. Insulin lowers blood glucose and glucagon increases blood glucose. So the way to remember is that glucagon increases blood glucose, so it's like G to G, and then insulin is just the other one. And in time, you will slowly remember it, but this is the quick way. Okay. And they are antagonistic. The functions of insulin and glucagon are antagonistic. Okay. Basically, after a meal, you secrete insulin so that you store all that glucose intake into your liver and tissues. Yeah. Okay, so diabetes mellitus, sweet urine. So diabetes mellitus means sweet urine. Okay, and they used to test this by tasting urine to test whether you're sweet. And it's distinguished from diabetes insipidus because insipidus means tasteless, so no taste. Okay, and it's caused by a different thing. So diabetes mellitus is prolonged hyperglycemia. There's type 1, type 2, and there's also gestational diabetes, which I won't cover. Type 1 is mainly caused by insulin deficiency, caused by autoimmune causes. Like your body attacks your pancreatic beta cells. And type 2 is caused by insulin resistance with varying levels of insulin deficiency. So in a type 2 diabetic patient, he may later require insulin as well, but he's still considered type 2, okay? Even though he may sort of be more type 1 later. Okay, and classically, the symptoms of diabetes, you get polyuria, polydipsia, polyphagia, weight loss. So poly means many, so many urine, so increased frequency, increased amount of urine you pass. Dipsia is thirst, and phagia is hunger. Okay. So diagnostic criteria of diabetes is basically symptoms plus one of the following tests. Okay. If you don't have symptoms, you need two positive tests on 2 separate occasions. And you can proceed to an oral glucose challenge test if they're ambiguous. I'll not go through that now. Okay, so something I will go through is C-peptide. So C-peptide is a marker of endogenous insulin production. So the physiology of it is that, so on the bottom right diagram, proinsulin is broken down into insulin and C-peptide. So C-peptide is just something that is cleaved off during this process and has no biological function, right? So you can measure C-peptide levels in the body to check for how much insulin the body itself is making versus how much insulin you are giving the patient. And this is because when we give insulin to patients, we don't give C-peptide, okay? Because it's useless, and also it allows us to do this test. So do not confuse C-reactive protein with these other things. Do not confuse C-peptide with these other things. So protein C, you guys will cover it in heme, and C-reactive protein is a third year thing. Okay, so this is a summary table comparing type 1 and type 2 diabetes. The main things to know are the onset. So type 1 occurs suddenly, as opposed to type 2, which occurs gradually, because in type 1, you only get symptoms when you have lost more than 80% of your pancreatic beta cells. Age of onset is generally younger in type 1. And for phenotype, type 1 patients tend to be thin and young, whereas and associated with other autoimmune diseases like Addison's, celiac, or thyroid autoimmune diseases. And in type 2, you're usually overweight. So importantly, so if you look at this, you look at the concordance in identical twins. For type 2 patients, they actually, so if you have a family history of diabetes, it's actually a stronger risk factor for type 2 diabetes than type 1, which is not that intuitive. Yeah. And okay, yeah. So complications of diabetes separated into microvascular, macrovascular, and glycemic. It's easy to remember because there are 3 things for each. Okay. So in microvascular, you have retinopathy, so eyes, kidney, nerves. Nerves can be sensory, motor, or autonomic. So most common is sensory loss in a glove and stocking distribution. So you lose sensation over your feet and hands, and this is a problem because diabetic patients lose sensation of their feet and start stepping on things, and they don't realize that they step on things. So you can step on like a nail and you don't realize it, and you just keep stepping on your foot and walking, and over time that can cause like gangrene and then requires amputation. So it's serious stuff. Glycemic complications of diabetes tend to be acute. So you can get DKA, diabetic ketoacidosis in type 1, and HHS in type 2. And you can get hypoglycemia from medication, which lowers blood glucose. Okay, so other complications of diabetes, the only ones that you need to know are in both, and they're found in the OSCE, and the other ones are good to know, I guess. Okay, so DKA versus HHS. I'll come back to this later if I have time. Okay, if my laptop has time. So target sugar levels. Basically in type 1, in diabetes, you have high glucose levels, and if you treat it by lowering the glucose levels, you can get hypoglycemic attacks, which is actually quite a big thing. So patients, if you have too low blood glucose, you can like suddenly faint, right? So this is a significant thing. So treatment of diabetes, lifestyle modifications are actually really important, especially for type 2. And often with like good lifestyle modifications, you don't need much medication. Okay. Type 1 generally treated with insulin. Type 2 you generally treat it with oral hypoglycemics. So any oral medications that lower your blood glucose. First choice is metformin, contraindicated in renal impairment. And if it's if you have renal impairment, you go to sulfonylureas. Okay, so this is a treatment for overview of the treatment for diabetes. So lifestyle management for all diabetics. In type 1, you can use insulin or this new drug called SGLT2 inhibitors. Have you guys heard about this? In renal, I think. Okay. I might go into it. And in type 2, you use all kinds of oral hypoglycemics, and you can also use insulin if you have lost too much of your beta cells over time and like a late stage type 2 diabetes. Okay, so insulin is basically given as a basal bolus regime because it's when you give insulin, you're just trying to mimic the physiological pancreatic function. Okay, so you give a basal level throughout the day, and for meals where there are spikes in glucose after meals, you give additional boluses of insulin for just after meals. Okay, so diabetic medications. Insulin sensitizers or insulin secretion. Okay, I'll just go through the things that I can value add. So for sulfonylureas, they are glycoside or glipizide, so they end with zide. Okay, but it's only these two drugs. These are the only two sulfonylureas that end with Zyte, because there are actually many other sulfonylureas out there which don't end with Zyte. But for the sake of exams, these are your two core drugs. Okay. Whereas for glitazones, so glitazones they work by different mechanisms. So they increase insulin sensitivity, whereas glicazide, so sulfonylureas, work by increasing insulin secretion. Then there's a third drug called glutinide. Glutinide is a different class to sulfonylureas and ends with nide, so that's how you differ. And they are second line to sulfonylureas if sulfonylureas are contraindicated. So